Okay, record. Apologies, Pastor Joy, for starting halfway. But anyway, where was I? Uh more yeah, more
Morphine.
yeah, morphine. Patient might the progression or onset of the disease can be so aggressive that the patient can feel nauseous and is also is probably maybe vomiting too. So you, besides morphine, you can give your antiemetic, and normal antiemetic is your metoclopramide. Very effective drug. Very there are almost no side effects, but you can't use it for a very long time because there's no point in using it for a very long time. You can just use it just for symptomatic treatment. But yeah, oxygenation, morphine, and metoclopramide. This is in the British um, guideline for treatment of ACS. Anyway, that's you can also continue to give nitrates too for pain. Right. Now that's done. Next, will still your first line of drug is your statins. Your statins. Now, if you're writing something, if you're writing it down, what we've been talking about, I want you to write something. I want you to write that statins, they are always indicated. They are always indicated in any coronary artery disease, any coronary artery diseases, unless contraindicated. Unless contraindicated. The contraindication is your myalgia. Patient already has as symptoms of myalgia, and the reason why the patient has myalgia is when you do your biochemical test, your creatinine phosphokinase, your creatinine phosphokinase is high. But remember, creatinine phosphokinase. I'm going to ask someone here. When do we detect creatinine phosphokinase? What is creatinine phosphokinase? Davai. Anybody? We talked about this when we learn about diagnosis of MI. Ogapi. Creatinine phosphokinase. Dun-dun.
What do you mean when?
Have you heard this before?
Uh-huh.
Wait. When?
Can I try?
Yeah, sure, of course.
Uh, uh, it's an it's an enzyme that is expressed in tissues or and cells. Right.
Okay. Mm-hmm. And how many types of CK, creatinine kinase, do you know?
Types.
Mm-hmm. Remember when we talked about diagnosis of MI, we
Mm-hmm.
want to find levels of cardiac markers, right? Remember? Your troponin and your
Yeah.
CKMB, your creatinine kinase MB fraction.
Mm-hmm.
Remember?
Yeah.
And so if you see elevation of CKMB, remember I remember showing the graph. the half-life of CKMB, and the half-life of troponin. And why do we prefer CKMB over your troponin? CKMB stands for creatinine kinase MB fraction.
Mhm.
And we talked about how the half-life of CKMB, it it drops down on the second day of the disease. So if there is another attack of MI, it will shoot back up and you can check CKMB again because it's more reliable. Whereas troponin, it's a bit slow. It will peak about second or third day of the disease and it will go down longer than your CKMB for MI. So that is why we don't troponin. It can still be used, but it won't be a reliable measure when it comes to recurrent MI because we are also scared of recurrent MI, right? So with that said, your CKMB, your creatinine kinase MB fraction, that means that there are different types of fractions of CKMB, different types of CKMB. The first type of your CKMB, your CK or creatinine kinase is MM, MM, MM fraction. Second is your BB fraction. Third is what we use as our cardiac enzyme, CKMB, your MB fraction. There are three types of your creatinine kinase. Now, why do we only measure your CKMB and not your MM or BB fraction? Because your CKMB is only in the heart. CK, creatinine kinase, is only produced when there is damage of muscles, any muscles, right? Like what Tiopo said, any muscles. And your CKMM is found in smooth muscles. Your CKBB is found in the brain, but your CKMB is in the heart. That is why we use that. So back to statins. So whenever we look at statins, one of the side effects of statins, most common side effect of statin is myalgia. And when we measure levels of CK, not MB, but MM, not MB, but MM, in patients taking long-term use of statins, especially when they already have the developed signs of myalgia or pain in the muscles, most common finding will be increase in your CKMM, your CKMM fraction, not your CKMB, because CKMB will be your heart, like we talked, and also not your CKBB because that's your brain, right? So, but then again, statins nevertheless will still be your first line of drug use in your ACS. So to complete the sentence that I wanted you to write earlier on, um, statins are always indicated in any coronary artery diseases unless contraindicated or intolerated, and it is also used even in normal cholesterol levels. Remember this, even in normal cholesterol levels. People
Why?
think, why? Because it's before this we just give statins in patient with high risk of high risk as in obese patients or patient with hyperlipidemia, right? Because they have high levels of cholesterol. But studies have shown that statins has is able to reduce mortality of any patient with coronary artery diseases by 25%. By 25%. And um, regardless of their levels of cholesterol, regardless level of cholesterol. And they don't see the significance of reducing your cholesterol too much. And we see that it is good. They have a better prognosis. It improves the prognosis by 25%. And this is in the um, guideline for treatment of unstable angina, the recent
Oh.
one this year. Yeah,
So can we say that statin is a preventive drug?
it is a preventive drug. Yeah, it it it's mostly on the prognosis side of your treatment more than your symptomatic treatment. So regardless of your level of cholesterol or lipoproteins, you still give um, your statins. Now, however, there is a specific um, level that we have to achieve with the use of statins, and if the patient has history of hyperlipidemia. Your LDL, or your low density lipoprotein, which you people might call the bad cholesterol, has to be less than 1.4 millimole per liter if the patient has a hyperlipidemic history. Okay, all right. Next thing, before I move on, aspirin itself in the guideline says that it reduces mortality by 25%, 25%, and clopidogrel reduces mortality by 18%. So from this percentage, you know that aspirin reduces mortality more than clopidogrel. Um, so yeah, you see, with statins, you could reduce mortality already by 25%. With aspirin, you can reduce mortality by 25% too. So 25 plus 25, you can reduce mortality by half already, just by the usage of statins and aspirin, right? Next, next. Next line of drug would be your beta blocker. We talked about beta blockers before, right? And beta blocker has what effects? Mm-mm-mm-mm. Which effect? Based on your cardiotropy.
Negative inotropic.
Negative inotropic, negative what again?
Mm, chromotropic.
Negative chromotropic, negative what again?
Dromo.
Dromotropic. Yeah, okay. You all negative, basically, all the negative stuff. In other words, um, from these three cardiotropy effects, in other words, a general term that people use when it comes to beta blocker use is that it has cardiodepressive effect. It has cardiodepressive effects. Right. Now, when it comes to the usage of beta blockers, again, beta blockers are used for the prognosis side of of um, of the treatment, and it is preferred that you use cardioselective beta blockers and not the non-selective beta blockers, right? Because you know that beta receptors are everywhere in the body, and um, if you give beta blockers, it's more preferred to use cardioselective beta blockers. So you can use um, the best one, the beta blocker that you can use based on the guideline is bisoprolol, 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 and your nebivolol, nebivolol, bivolol, nebivolol. You can give carvedilol as well. You can give mesaprolol as well. But the best would be your bisoprolol, bisoprolol, and your nebivolol. We don't have to go through the contraindication, right? We talked about the contraindication before you change. You have to go through them when you are revising anything before. So we use beta blockers as your first line unless contraindicated. Contraindicated. So also your beta blockers reduces mortality by another 25%. So you have about 75% of mortality reduction already. Now, if your beta blockers are contraindicated, it means patients who are in acute heart failure, patient with asthma, and all that. If beta blockers are contraindicated, you can give calcium channel blockers. But the thing about calcium channel blockers is that it's best not even being used. It is considered third line of treatment, not even second. By the way, it's considered third line of treatment. And reason why calcium channel blockers are not used is because it has general vasodilative effect. It includes even peripheral vessels, and also vessels that are close to the heart, and not just coronary vessels, mind you, not just coronary vessels, but also vessels that is close to the heart. It means that it includes your aorta, your vena cava, and stuff, all those different types of vessel. So why is it so bad that that vessels are dilated? It means when these are the two terms that you need to remember too, and I'm sure that you've heard this before, but I'm not really sure if everybody understand what it means. The term preload and postload. Preload and postload, I think. Postload, right? Postload.
Afterload.
Afterload, postload. Right. Your preload and your afterload. Right. Now, what do these two terms mean? Preload, it simply means the ability of your cardiomyocytes to stretch, to hold blood in the heart. And your afterload, it means the amount of resistance that the heart has to fight so that the tissues can be perfused. So these are the two terms that you probably have heard. You have a question? Repeat. Preload refers to the ability of your heart muscles, your cardiomyocytes, to stretch in order to hold blood. Like your ventricles, they have to hold blood, right? It means that the higher your preload, the more blood that is in your heart. Your afterload. Hmm? Afterload refers to the amount of resistance the heart has to go against so that the tissues will be perfused.
Okay, thank you.
So what do calcium channel blockers do? All calcium channel antagonists, the same name, your let's call them CCBs. The calcium channel blockers, what they do is that they have a very generalized vasodilative effect. It means that your heart has to pump more so that um, the so that it can it, sorry, in other words, nabarot, it means that the vessels will be dilated, and your heart your preload will be lowered, because there's no need to fight anymore. There's no resistance, because when it's a reflex, right? When there is higher resistance, it means your heart will try to compensate and try to pump harder, right? But now that the vessels are dilated, well, the vessels are like, meh, the heart is like, there's no need for me to have too much blood. There's no need for me to pump that much. So it has some level of, that is where the cardiodepressive effect comes into place. And it can be a little bit dangerous, because you don't want the vasodilative effect, especially when it comes to this. Of course, for example, we use nitrates for that, right? We already use nitrates for vasodilative effect. And if we give calcium channel blockers again, the vessels are so dilated. So that is why calcium channel blockers are not really preferable. But if it, it, it reaches to that point, we're going to have to use calcium channel blockers for the um, cardiodepressive effect. Now, this is where the art of your prescription and your drug administration comes into place, because you cannot just simply give calcium channel blockers. Remember we talked about calcium channel blockers and how they are divided into your dihydropyridine, right? Your dipines, amlodipine, nifedipine, all those dipines, and your non-dihydropyridine calcium channel blockers, which are your verapamil and diltiazem, right? And remember that your non-dehydro non-DHP non-dihydropyridine calcium channel blockers, they are not selective. It means that they affect both the heart and peripheral vessels. But your dihydropyridine, they affect mainly your vessel, your heart. So that is why if it reaches to a point where you have to use calcium channel blockers, you're going to have to use non-dihydropyridine calcium channel blockers, which are your verapamil and diltiazem. Right. Now, with that being said, those are one of the few first line of drugs. Did I miss? All right. ACE inhibitors. ACE inhibitors. It's not really used in ACS, but they are first line of drugs for stable angina. Stable angina. But regardless, sometimes your stable angina can progress into non-stable angina, and your non-stable angina can also progress into MI. So you can also give um, ACE inhibitors, your ACE inhibitors, um, or your ARB, angiotensin receptor blocker inhibitors. You don't give ACE inhibitors and ARB together, because they affect the same system, your renin-angiotensin system. You can only give either one. You don't give them both. If you want to give ACE inhibitors, your pril, your captopril, lisinopril, pril. The risk and a side effect that is very common for ACE inhibitors will be your dry cough. Of course, when it comes to treatment of ACS, it's an emergency, right? And probably the patient will be hospitalized only probably for 2-3 weeks max. And ACE inhibitors are normally used also used in first line treatment for hypertension. One of the side effects of captopril is when the patient cannot tolerate it. In other words, is dry cough. Why? Because your ACE inhibitors, not especially ACE inhibitors, they don't just only affect your renin-angiotensin cycle. For ACE inhibitor specifically, it also affects your bradykinin cycle. Now, when your bradykinin is not produced, this is where, or is it produced? It's produced. When there is bradykinin produced, the you'll have your dry cough. There is one of the most common side effects of ACE inhibitors. Another side effect of ACE inhibitor would be your edema, especially pedal edema. Very minimal pedal edema. You can ask patients with history of hypertension or is controlling the hypertension. Some of them, they have to change to angiotensin, your ARB angiotensin receptor blockers because of the edema, because of the pedal edema. My dad, for example, had to change his captopril into your one of the sartans, your ARB, in other words, because of pedal edema. He did not have any dry cough, but he had pedal edema, one of the most common side effects of ACE inhibitors. So yeah, regardless, in angina, you can give ACE inhibitors or ARB, and the best ACE inhibitors that you can give is perindopril, based on the guideline, perindopril, 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 and ramipril. Another reason why ACE inhibitors are used is because they have nephroprotective effect. Again, because of inhibition of the renin-angiotensin system that belongs to your kidney. And it might not be one of the thing that you want to fear when it comes to ACS, because it's mostly in the heart. But when it comes to hypertension, you will need some form of nephroprotectors, some form of kidney protectors, and that is why your ACE inhibitors or ARB comes into the picture. Again, ACE inhibitors and ARB, they reduce mortality by 25%. So you know that ACE inhibitor, aspirin reduce mortality by 25. Your beta blockers reduce mortality by 25%. Your what else? Your heparin reduces mortality by heparin, was it? I don't remember. Your statins reduces mortality by 25%. Now your ACE inhibitors reduces mortality by 25%. So you have already 100% of mortality reduced. So it's that is why they are called first line of treatment. They reduce mortality by 25%, by 100%, if not close to 100%. So yeah, that. Oh, anybody with question?
Yeah, I have a question.
Mm-hmm.
Meaning, for stable angina and CHF, the first line of treatment is ACE inhibitors. What for ACS is the thing the NSA
Mm-hmm.
treatment.
Mm-hmm. Your NSAIDs, heparin, beta blockers, and statins.
Okay, for CHF is AC and ARB.
Will
First line.
first line of treatment? Yes, yes. One of them. One. We're not going to go into CHF yet, but one of them, yes, ACE inhibitors is one of the first line,
Okay.
and beta blockers. Right. Let's see if I've covered most of what I want to talk about. I talked about statins, everything I've already talked about. Beta blockers, nitrates, ACE inhibitors. ACE inhibitors talked about. Let me show you a picture. Oh, oh. Right. Can everybody see this?
Yes.
Dark. This. Oh, I hope it's not too dark though. But yeah, this is the hard drive. Obviously, I want to talk about when you perform angiography. You know, one of the diagnostic methods to diagnose your angina or your MI is to perform angiography, right? And this is what you might notice some patterns. One of the main anatomical branches of your coronary arteries. By the way, this root like things, they are your coronary arteries if you've not realized. So the big ones, the important ones, it will be a left anterior descending. See, a left anterior descending. It points to this one, right? This big branch of artery. Now, if you see any occlusion here, any for whatever reason, for whatever reason, thrombosis or your atherosclerotic plaque in this vessel, or for whatever reason your left anterior descending artery is stenosed, um, you will see in your ECG that your MI will be anterior wall, your anterior wall, and to some extension septum, The slightly red one is refers to the one at the back, right? The slightly red one will be at the back. So the first one just now we talked about is left anterior descending artery. The next one will be your left circumflex artery. By the way, this side is left, this side is right, right? Okay. Left left circumflex artery, this one over here. If you notice, it goes to the back. It goes to the back. So in other words, your left circumflex, oh, my internet is unstable. I hope I'm not cracking. Am I cracking? Hello? Am I cracking?
You were.
Am I cracking now?
No.
Okay, good. All right. Your left anterior circumflex artery, it means that if you see any form of stenosis in this branch, your you would expect on your ECG for lateral and inferior wall of MI. Lateral, you see lateral this side, the sides, and inferior walls, because you see it goes down over here, inferior walls. Sometimes your anterior descending artery also can have inferior walls. Okay? You see here inferior walls. Next will be your right coronary artery. Right coronary artery over here. This very big one over here. Right coronary artery, you see it covers not just the front a little, and it also covers the back. But just the anterior side is only smaller. It has a small branch, your right marginal artery, and that's it. And most of the branches will be to the back. So that's why if you see any stenosis in your right coronary artery, you will see mostly posterior infarction and a little bit of anterior inferior, or septal. But most of them, most of the infarction site will be your posterior walls. Okay. Next would be fibrinolytics. We are still talking about blood now, blood related. It is not the first line of drug that we use in ACS, but it can still be used if we suspect or we have confirmed that the cause of the um, attack is because of thrombosis or thromboembolism. So we can give thrombolytics or fibrinolytics, the same term. Very commonly used fibrinolytic would be your TPA, your tissue plasminogen activator, your Altiplus, ALTEPLASE, your Altiplus, your TPA, your tissue plasminogen um, activator, not inhibitor, TPA. Other fibrinolytics include your streptokinase and urokinase. However, we no longer use streptokinase and we no longer use urokinase anymore. Probably urokinase a little bit, but streptokinase no longer used. The reason why streptokinase no longer used because of the nature of streptokinase itself. Remember that if you remember clearly, one of the toxins of streptococcus, any streptococcus is streptokinase, one of the toxins, yeah, that streptococcus, any strains of streptococcus produce is your streptokinase. That is how they actually manufacture streptokinase in the first place. They took the toxins from streptokinase, from streptococcus, um, and manufacture some form of fibrinolytic. And the reason why it's not being used anymore because of the prevalence of streptococcus antigen that is used in strepto in the manufacturing of streptokinase fibrinolytic. And the reason why it's not being used because some people, because streptococcus is a very common bacteria that infects people, right? Anything from sore throat, from anything basically, because it's a what's the word? It's widespread. Is another word for widespread. It's what's another word for widespread? Can't remember. It's a very fancy word. Not really that fancy, but M. I must know this word. Widespread synonyms. Ubiquitous. 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 They are ubiquitous bacteria, and that is why some people they have already developed some form of immunity towards streptococcus, any form of streptococcus, and especially their antigenic structure. That is why when you give streptokinase, the immune system is just gets rid of it and it's not effective anymore. So people now they don't use streptokinase anymore. Urokinase maybe, but urokinase is not taken from any streptococcus strain. It's taken from neonatal kidney cells. So it's not much. It's still not very much use, but well, probably it's used somewhere. But most commonly used would be your TPA, your tissue plasminogen activator or Altiplus. Okay. That will be all today. Unless we want to talk a little bit. Oh, talking about fibrinolytic, a way to know effectiveness of your fibrinolytic will be your TIMI score, your TIMI score, TIMI score, or what was the other one? What was the other one? TIMI score and your forget. I think your ST. Your decrease of your ST elevation by 50%. You see that your ST elevation it's improving. It means that it's going back to the ISO line, and most of it is improving by 50%. That's one of the criteria for effective fibrinolytic. Another criteria for effective fibrinolytic is your TIMI score. Let me show you TIMI score. TIMI score. This is TIMI score. TIMI score. This is how you score it, but the result of your TIMI score, if you're interested, I couldn't find a clear result for TIMI score. You see that the score there it says 0, 1, 2, 3, 4, 5, right? So yeah, TIMI score in degree, the 0 degree, there is absence of blood flow. It means that it is not effective. First 0 degree. The first degree is minimal blood flow, and it appears below the place of occlusion. That's the first degree of TIMI score. Second degree of TIMI score, partial blood flow. The blood flows below the occlusion, but it is still slower than normal condition. That's second degree. Third degree, complete reperfusion. It means that the fibrinolytic the fibrinolysis is so effective that there's no more occlusion anymore. Complete reperfusion, and it fills the vessel, the artery completely and almost as quick as normal. That's the third degree. So this is TIMI score for unstable angina and your non-STEMI or STEMI if you want to use fibrinolytic. Okay. Do you guys have any questions? Surgical treatment. Surgical treatment we're not going to cover because remember we only cover mostly internal medicine. Surgical treatment will be your percutaneous coronary intervention, your PCI, which means that you are performing angioplasty plus insertion of stents into your artery, balloon angioplasty, and insertion of stents. That's number one. Number two is your CABG, CABG, coronary artery bypass graft. You remove the entire, you get rid of the entire vessel, the entire coronary artery, and you get this from somewhere, maybe from somewhere else. Maybe it's either from the patient itself or from a donor, and you graft it onto the heart and fix it back, and that is your CABG or CABG. People just call it CABG. I don't know why. Maybe because it's easier to call it CABG rather than CABG. So yeah, those are the surgical options that you can use if indicated or if the stenosis is very, very severe. Any questions? I hope everything is clear. I hope. Hmm? I can't hear you. I still can't hear you.
Can you hear me now?
Very faintly, yeah.
Yeah, I said yes. I said it. Thank you.
Oh, okay.
Big thank you.
Okay, I hear you. You say niet and a very, very, very big thank you. You're welcome. You're welcome. Mm.
Do we use what about cardioversion?
We can actually use cardioversion as elective. I've read that you can give cardioversion once the patient is stabilized. But the thing about cardioversion is that because MI is a very acute disease, acute problem, and that cardioversion, and that sometimes it might be tempting to you to defibrillate, to apply defibrillator on the patient, but that's not effective. But cardioversion, yes, probably will work, I guess. I will still need to read up on this first. It's not in the guideline that I've been reading, and maybe you can read it up to. Probably, I don't know. It might work. It's not in the guideline here that I read. I've read a couple of guidelines just to be sure of what I'm talking about, but none of them talked about cardioversion, so I'm not really sure how effective cardioversion when it comes to ACS treatment.
Okay, thank you.
Sure. Any other questions?
Нет вопрос.
Нету. Отлично. Так, тогда все. Next, what would you guys like to talk about next? Because honestly, the next, if we want to still continue on CVS, we can continue on maybe hypertension and stuff like that. But the treatment will still be almost the same set of drugs. If you would like to hear it again, the same set of drugs, your beta blockers and all that. The only difference will be which one is first line, which one is second, and which one is third line. That's it. That's the difference. And why are they effective? And why are they indicated in this type of diseases? But pretty much, the mechanism of action will still be the same. Still be the same. So, would you guys like to stay on CVS?
We can do hypertension and yeah. Maybe you can do two topics at the same time, right?
If we have time.
Because I
Ivy,
think
huh?
maybe we can also do infective endocarditis.
We can. That's a very good idea. Infective endocarditis. Very interesting. Uh, Definitely not boring because we talked about all the beta blockers, ACE inhibitors, or calcium channel blockers repeatedly. Ivy, you wanted to say something?
I agree with you, Paul.
Okay.
I just want to hear why this treatment is better than the other treatment for hypertension, blah blah blah.
Okay. All right then. So next class will either cover hypertension and probably congestive heart disease. Yeah, congestive heart disease, both your acute and chronic heart failure. And treatment is pretty much almost, the drugs are almost the same. All right. Если нету вопросы, тогда пока-пока.
Хорошо, до свидания.
Спасибо, до свидания.
Все, пока.